It is not a lack of evidence, the rationale to treat AF. Just finding out how this works. Next, okay, like this. First of all, we have to recognize if there is evidence for a problem. And then some facts. More than 33 million people suffer from AFib worldwide. And you might say on 8 billion, that's not a lot. But we know for a fact that from the age of 75, 15% of the people start to have AF. Secondly, if you have AF, your risk to have a stroke is 5 times higher. Thirdly, if you have AF, your risk for having heart failure also increases with 5 times. And we know as surgeons that we do not treat all of our patients. In fact, only 1 in 3 patients with AFib is treated properly during our procedures. This is a slide from the Annals of Thoracic Surgery, SCTS data, where you see divided over periods of 6 months up to 2014, the slow increase in concomitant procedures. The highest line depicts the concomitant procedure in mitral valve, and then the second line on top, CABG, and so on. So a slow increase. Here you see the answers to a questionnaire asked to surgeons on a 2010 AATS meeting. The answers depict reasons given not for treating concomitant AF. And it varies from I had too much complexity, I had too much pump time, results were not reproducible, not willing to add a risk, and lack of society consensus. Complexity, pump time, and risk. Concern about the risk. Is there an added risk by performing concomitant AFib surgery? In 2012, NIVET already published a very beautiful propensity scored analysis of more than 5,000 patients, wherein his patients were AVR and CABG patients, and in his conclusion he clearly stated that the addition of the Cox-Maze-3 procedure to AVR or CABG did not convey an increase in major morbidity and perioperative risk. These data here depict STS data, and you see here on what kind of numbers of patients we're talking. And take a close look to group 3 and 4, 10,780 patients with AF without surgical ablation. Group 4, 16,300 patients with AF that underwent surgical ablation. If you look to some of the most important risk factors like operative mortality, reoperation for bleeding, sternal infection, permanent stroke, prolonged ventilation, or new onset of renal failure, all of the results were in favor of adding a surgical ablation to our procedure, except for sternal infection. The slide you see here depicts data published by Richard Whitlock, a Canadian who performed the most extensive meta-analysis so far. Here depicts are the data on mortality, and he clearly stated that mortality was not increased by adding a surgical ablation to your procedure. Results are not reproducible, another comment by many surgeons in 2010 on that AATS meeting. And this is a very busy slide. I'm trying to guide you through it, but it starts with publication going to the 80s and the 90s, where Cox designed or described the procedure. And then in the 90s and the early 2000s, where many of our colleagues published new ideas, new technologies, new approaches in treating atrial fibrillation, and actually causing a lot of confusion. And it's only now, since about 8 years, that the guidelines gave us some more direction in how to treat which kind of patient with atrial fibrillation. What about results? Do we restore sinus rhythm after our procedure? And I think one of the most clearest examples is the publication by Mark Gillenhoff, published in 2015 in the New England Journal, describing patients with atrial fibrillation that underwent mitral valve surgery and were randomized in with or without surgical ablation. And as you can see here, clearly the risk of ending up in sinus rhythm was doubled as high if you had a surgical ablation. These are data from our own country. So we recently published on a national registry that we had to do in order to get reimbursement for the ablation material. And you see a variety of outcome parameters, paroxysmal versus non-paroxysmal, mitral versus non-mitral, and different kinds of procedure. But as you can see to the outcome, the results, clearly we did something to our patients because quite a lot of our patients were effectively in sinus rhythm at 1 year after the procedure. Again, Richard Whitlock's paper, Restoration to Sinus Rhythm. He debates here 20 studies and reported on freedom from AF at 12 months. And as you can see, the relative risk was clearly in favor of adding an ablation to your procedure to have sinus rhythm after 1 year. What about biatrial versus left-sided alone? Again, Richard Whitlock, where he compared biatrial versus left-sided. There was no significant difference looking at mortality, stroke, hospital length of stay. The relative risk, however, for both biatrial and left-sided was 2.8 for biatrial and 2 for left-sided. So clearly a bit higher for a biatrial approach to achieve sinus rhythm at 1 year, but this difference did not reach statistical significance. What about freedom from stroke? Again, the SCTS data. And then you see that the ratio for patients that underwent surgical ablation, 1.5, was clearly better than those without a surgical ablation. Survival. Do we improve survival after surgical ablation? On the right upper hand side, a slide from 2012, where you see that a variety of surgeries, those patients with surgical ablation clearly did better with regard, even up to 5 years after the procedure. And the same is true on the left lower hand side after cabbage surgery up to 2 years after the procedure. What about society consensus? And then I think this slide says it all. It depicts how all societies, both cardiological and surgical, increased their level of, not only the level of evidence, but also the level of recommendation up to the most recent year. In 2017, the SCTS even mentioned a 1A recommendation for patients undergoing mitral valve surgery, where you had to add an ablation if they have atrial fibrillation, and a 1B recommendation for AVR and cabbage surgery. So to come to a conclusion, I try to show you that, yes, there is evidence of a problem when it comes to atrial fibrillation. We have to recognize there is still a gap between the need and the reality. I try to tackle some of the reasons that surgeons gave who didn't treat AF during their procedures. And I also try to depict some evidence of a solution. Surgical ablation restores sinus rhythm. Surgical ablation is safe. Surgical ablation improves outcome. And the guidelines are actually pretty firm, definitely if you look to the SCTS guidelines of 2017. I would like to thank you for your attention.